I'm Bill Wolff. I'm the executive director of LaSalle School in Albany, New York, upstate, in the capital. And I'm just going to try to very quickly give a few examples from the field in these areas of influence that I think ACES has, knowledge of ACES and trauma-informed work has helped us at LaSalle. At the agency level, I guess my reaction to it was right on our campus. We have 6 acres in downtown Albany. It's developing and the effect is evident, what's happening with our culture. At the local and regional level, it's challenging. There's a lot of emerging practice that's exciting what's going on, I would say, within, let's say, the 15 or maybe 50 mile or multiple county ratio around the city there. And at the national level, it's pretty humbling and at the same time energizing. I mean, we're all, I will not proclaim to be any sort of an expert in this at all. A little context about LaSalle School. It was founded 160 years ago. It's on the same place it was then, and primarily a long history as a residential provider. You look back, the orphanage model, that kind of stuff. We're still very heavily entrenched with residential adolescent work that actually has its traditions back 300 years ago to France with St. John Baptiste de LaSalle, the French Christian brothers that are all over the place. They run a bunch of prep high schools. They also run or are affiliated with like Manhattan College, LaSalle, and much work with the poor. Very, very exciting kind of tradition. A great wealth of mission to link onto, though, and this work makes a lot of sense. So let's see, influence at LaSalle School. So I just wanted to touch on this a bit, of this idea of using knowledge of ACEs and childhood trauma to influence the culture. The thing we stumbled into through some colleagues about 12 years ago involved a collaboration with the university at Albany and their School of Social Welfare. Very, very lucky. We've worked hard at it, but there's a lot of stuff we have, like kids, families and kids who their social workers are very interested in working with, field experiences, all kinds of things like that, opportunities for research, opportunities to really be out there. Actually, in the material here, Dr. Heather Larkin, I think, in one of the very first, there's the thick pamphlet, I forget exactly all it is, but you'll see she's talking, she doesn't mention us, but she's talking partly about us in her little research study of her work in upstate New York in ACEs and response. That's been very good, and it's evolved, and it gives us, I can't tell you all of the things it does, but I'll tell you this, that this partnership with the university is energizing to our staff. It's not a burden to them. It's helping us with data, it's helping us with retrieval of data and other information like that. But for many of our professional staff especially, it's just great to sit down, as they'll say, to really look at these kinds of situations with this and have those kinds of discussions. That's been terrific. I don't think it's essential, but I think it's something that we all should be looking for. Integration into the workforce training, especially of our child. We're a residential center, so we're downstream. We've got adolescent kids who, their list of, I'll show you in a second. We don't do a lot of early childhood work, or especially Latin. I mean, I have certainly obviously an interest in that, but okay, my main interest is LaSalle. What are we doing here? So we're working with downstream kids who come to us who are very, very troubled in New York State. To give you a sample, this is one of the ways that I help folks understand who are very new to these kids. In New York State, there's about 3 million school-aged kids, ages 5 to 18, the last sentence, or the last census tells us. In our system of care, not LaSalle School, but our system of care that works with these kinds of youngsters just in New York State, it varies, but in residential programming, there's about 15,000 kids. 15,000 out of 3 million school-aged kids. These are rare, needy kids. This is not, the pathway for these kids to get to us is not one that is sort of less than traumatized, filled with trauma, obviously. So that gives you some idea about that. We're starting to use ACE screening on all of our youth in the program, and when we do that, we don't screen the kid, obviously. We really accumulate information from the record and from other stuff like that. We're experimenting with this. We're not sitting a child down and go, question 1, what's your response? Question 2, what's your response? Question 3, and then we look for help because by then the kid is decompensated. We're not doing that kind of thing. But we're getting data. Data is key, but we can't get enough, and we kind of don't know what to do with it, and what we do with it is not always what our payers want us to be doing with it. So we wind up using it, for example, at treatment conferences, where we're starting to go into those conferences and work where we can help, for example, those child care workers who are getting significant amount of training, how they can begin to see changes in the youngsters' data or performance behaviorally, for example, over 3 or 4 months, and they lap it up. The other thing back on this integration into all workforce training is that our chief clinician trains side by side with, we do about 40 hours of training in New York State in therapeutic crisis intervention, and then about 12 hours of annual updates of that staff. Our director of clinical services is side by side with our direct care staff trainer. The folks who spend so much, we can't waste Saturday night. And we can't have folks just sort of watching the kids. And we can't have them using technology that they brought from their own experiences, because we know those jobs are generally very low-paying jobs. They're also from folks with the least kinds of training we have. So we have to have a mechanism to talk with them in a common vocabulary. And one of the things I'm most proud of in our agency, when we have a Christmas party every year, and it's held in the cafeteria, and our chief of psychiatry will sit down at the table with a bunch of child care workers. That's cool, and they know what they're talking. They know each other, they know what they're talking about. And they don't sit there and talk about ACEs, but that's because he's been in the unit talking with them about this kind of trauma work and the other things and what the data is telling us. Okay. And also, it gives us a chance to go back to our counties and report about the kids they're sending, because a lot of them don't have any idea really what's going on with the kids that bubble up through the system and get to family courts or wherever else. They're like, tell me about this kid. So this is some of the preliminary data about the ACE scores of kids at LaSalle School. I think it's about 125 or 150 kids. And you'll see that about 43% of the kids are scoring 5s or higher on the, and I don't want to drill into whether this was the exact science in the administration of this, and we know that when you're talking to a 14 or 15-year-old or reading their case record, they're not done with their experiences yet. I mean, but if we also had some stuff to compare with the population of adults based on a representative sample of adults, and I think this is from national data. And basically, you'll see that over on the right-hand side, in the general population, maybe 7 or 8% of the general population is scoring in this range of 5 or plus, and where we've got 42% of our adolescents scoring. Okay. So that's driving culture within our organization. It's changing stuff. And this is a very, very traditional residential program. I mean, 160 years we've been operating, so we've had to work hard at this. There's locally, though, on a level, there's an interesting group called this Hearts initiative that's underway, and this is in collaboration with the university, and Dr. Heather Larkin, again, is at this, and Healthy Environments and Relationships that Support. This is a coalition of Capital Region District human-serving providers, and we have diverse specialties. Honestly, we have the Homeless Aid Society, Homeless Traveler Society people there. We have Salvation Army there. We have a group that works with chemically addicted women over the age of 50. That's their profile they work with. We have children, young 30 or 40. We can put a room like this together from the Albany region of providers. And the ACE is a unifying language. When someone walks into comes into the shelter who's age 45 or 50, it really helps those workers to think, what's likely to have brought this person here, and what sort of trauma have they experienced? That dialogue is very valuable. And it's dedicated to building this community capacity. One of the meetings we had with this group recently, and the university convened this meeting we were there, and a bunch of us had a chance to speak and talk about our experiences, but there was the chief of police of the city of Albany, a couple of other surrounding areas in the county of Albany. The county executive was there. A couple of the county legislators were there. The director of probation was there. So, a couple of people in the hospital network were there. So bringing those people together to have a common dialogue around this ACE thing is very important that this group is doing. Very cool to be part of that. And workforce development and policy advocacy. So that's the kind of thing that we're talking about, is a way that we can reach out locally and be part of a network. We're not carrying the ball on that exactly. Albany is a strange place in the sense, it's the capital of New York, so we have our deal. But it's a strange place with the wealth of providers, of nonprofit providers that are there. National level, our objectives are certainly to gain knowledge, We're sending staff all the time to AACRC, the Alliance, all those kinds of things to pick up knowledge about that. And we're also participating in webinars and learning and so on. So our staff are able to do things. I mean, that's one of the, if you want to do this, you can't keep everybody on the campus. You've got to let them go out and interact and go, aha, whoa, okay, I understand. And there's no one person inside the organization that can carry it. You really have to commit to letting your people go. And we're also committed at a national level to sharing knowledge. A lot of our staff are presenters at the AACRC, here, elsewhere, often with the University of Albany, publishing and things like that. Again, the university is very interested in that. They have lots of folks who are PhD candidates who want to do their doctoral research. They obviously want to do that kind of work, and that's very beneficial for them. It's quid pro quo. We have them hanging around our campus, working with our kids, working with our staff, enriching this environment, and our staff feel very validated by it. Publishing. And we even got involved in the CRG discussion back and forth about how trauma, and particularly trauma with foster care kids, ought to create some different kind of situations with respect to the CRG diagnostics for what's emerging for all of the medical classifications for the prescriptive treatment. Basically, this, to be in a nutshell, it's a lot different when there's a foster care kid who may have been abused who walks into a pediatrician's office with a fracture. Big difference for that pediatrician to understand that he or she is dealing possibly with a youngster who didn't attain that fracture by falling off a bike or otherwise, or it might have been repetitive or other. So that was the kind of discussion that we had that with the CRG thing. That was really, I got to tell you honestly, I didn't really know what was going on, but we had some people in the office on the speakerphone that were kind of playing back and forth, and it was very fascinating, the whole thing. So those are some of the things that we're doing at LaSalle. It's very energizing, very empowering, and it's given us a platform for common interest and common dialogue. So it's terrific.